Again, welcome everybody. We'll give this a little bit just so everyone can get in, and then we'll go ahead and introduce our next speaker. All right, everybody, thanks for coming back and welcome again. It's been a couple years since we've heard from our next speaker, Dr. Clarke from the Mayo Clinic in Rochester, Minnesota. It is honored to have him back again, and this time he's going to be speaking on basal ganglia calcifications. And with that, we'd like to welcome Dr. Bart Clarke.
All right, well, thank you very much. It's good to be with you again, and I'll wish you good morning, good afternoon, or good evening, wherever you are. This is an international conference, and the pandemic has allowed us to do this in a virtual way much more than ever before. So I hope you'll enjoy this presentation. As was mentioned, this will be on basal ganglia calcification, which I think most of us have heard about at the various conferences, but not much has been said because not much is known about this. And so my research fellow and I, Dr. Guido Zavata, who came to join me for a year from the University of Bologna in Italy, we thought this would be an interesting topic to explore in our institutional database. And so I'll be presenting some of the results of this, but also giving you some more background to give you perspective on this. So here's my disclosures. There's no financial relationships or off-label use to be discussed today. And so we'll start with what are the basal ganglia, because I think most of us have heard this name thrown around. We know it's important, but in particular, it's important in hypoparathyroidism. Question is, what is it and what does it do? So I've just pulled an image here from Wikipedia showing basal ganglia anatomy, so you kind of know what we're talking about. This is part of the brain that includes a number of what they call nuclei, collections of cells within the brain. And the basal ganglia are shown in red, so you can sort of take a look at those. You see that there's several of them. Some are bigger, some are smaller. There's also related structures in purple. So the basal ganglia includes the caudate nucleus, the globus pallidus, the putamen, and then subthalamic nucleus, and coming further down, substantia nigra. There's also a ventral pallidum, and there's an olfactory tubercle and nucleus accumbens. Now, these are not common terms or names you use every day, so don't worry about the amount of them, but there's a number of them that are here. And their importance to our condition is that, of course, they calcify in time. And so we'll talk a little bit more about what they do and why we might expect certain side effects from this. So this shows another view looking at the brain from the front, and this brain is being viewed from the underside in front, and several of these nuclei are splayed out so you can see them in more detail. The corpus striatum, shown in the bottom left here, is composed of the caudate nucleus and what's called the lenticular nucleus, including several other subnuclei, the globus pallidus and the putamen. These are shown in mostly purple on the slide. You can also see the thalamus, which is in green, the big thing in the middle. And of course, that's important because that's a relay station for these different nuclei to communicate to different other parts of the brain, including the cortex above and other parts of the brain within the brain. We won't spend a lot more time on this. Now, what do these basal ganglia do? There's a very nice review I've pulled up here, and you can see the reference. This is written for scientists, so it's not easy to understand, even for me, because I don't work in this area. I'm not a neurologist, but it does give us enough detail here to sort of give perspective on what this part of the brain does. And so the basal ganglia, BG for short, are several groups of these subcortical cells or nuclei primarily involved in control of body movement. So you might think this is a pretty important collection of cells because you don't move well without them, or if they're somehow damaged. The original view back in the 1920s was that these ganglia regulated body movement after receiving inputs from the brain cortex, the higher centers in the brain, so to speak, and then sending these outputs back to the cortex in a loop. And this loop included the thalamus. This was the early view on these particular ganglia. Now, the current view is currently more complex, as you might expect, with much more research over the last 70 years. And these basal ganglia now have thought to have several parallel loops that regulate movement, but also associate basal ganglia communications with associative and limbic emotional territories in the brain, which are other parts of the brain that we won't spend time on today, but they communicate sort of at the center of the brain, both with the cortex above and then these other parts of the brain. And these movements or the loops now are thought to affect movement clearly, just as they were before. But with further research, it's also been clear that these affect our attention span, our time estimate or ability to estimate time. It also affects our learning abilities, habit formation, and then even reward-related behaviors and emotions. So clearly these are complex. It's not just movement that these regulate in the brain. Now, they're currently composed of 3 different groups of nuclei. There's input nuclei from the caudate, the putamen and the accumbens nuclei that receive input from the cortex, the thalamus, and the substantia nigra, which are other parts of the brain. So they're taking in this input and then passing it on to the intrinsic nuclei. These include a variety of nuclei, which maybe I won't take the time to go through here because there's a number of them. You can see the words there. And of course, these intrinsic nuclei process the information between the input that they receive from other parts of the brain and then the output that is sent through the output nuclei. And so, if you will, there's computing that goes on between receiving message and sending message out. The output nuclei include the internal segment of the globus pallidus and another nucleus called the substantia nigra pars reticulata, with the abbreviation shown. And then these send information from the basal ganglia mainly to the thalamus. All right, so this is a complex set of brain cells that are organized in a certain way to help process information. If you know anything about basal ganglia, you'll remember that dopamine is a key neurotransmitter in the brain at these nuclei, and apparently it's mostly released at the input nuclei stage. So this is very important. And if you either don't make enough or can't regulate dopamine production, what happens is you'll get what they call Parkinsonism. This is where your muscles don't move well. You become fairly rigid. You can't move or walk easily. And of course, sometimes you have muscle spasm and you can have other features as well. But beyond Parkinsonism, this dopamine is also important in preventing what's called dystonia, where muscles will spasm for a long time and force limbs to be in a certain position, for example, or another condition called hemiballismus, where parts of you can move spontaneously in sort of a flowing fashion from one part of the body to the other. And of course, neurologists see this all the time. The rest of us don't, but this is what we've all learned in medical school, and it gives you some sense of the complexity of these basal ganglia. So a very important part of the brain, mostly affects your ability to move easily. Now, this shows a diagram of these various different ganglia within the brain. These are all basal ganglia parts, and you can see that there's a lot of crosstalk that goes on. There's excitatory neurons in red that project from the cerebral cortex to the striatum to the subthalamic nucleus. And then there's feedback from the thalamus back to the cerebral cortex that you can see in red arrows. There's also inhibitory input that's in blue. I won't take the time to go through this. And then the dopaminergic neurons that use dopamine as the neurotransmitter here are shown in green. So clearly the substantia nigra pars compacta, the SNC nucleus, receives a lot and puts out a lot of dopamine. That's one part of the brain that's important in regulating these various functions. We won't take a lot of time to explain this in more detail because it's complicated even for the neurologists. Now, turning to basal ganglia calcification and what we know about it and how this has evolved over time, I show you this publication partly because it comes from my own institution. Back in the 1940s, 1947, this was published, And this shows a paper, one of the earliest papers. It's the first paper I could find in PubMed, which is our search engine for medical literature, that showed or talked about symmetric cerebral calcification followed postoperatively after parathyroid surgery and parathyroid insufficiency developed. Report of a case. This is the first case of post-surgical hypoparathyroidism I was able to find. And one of the authors on this, L.M. Eaton, that's shown below, spent his master's thesis time looking at these symmetric cerebral calcifications that had been recently reported at that time back in the mid-1930s. And so he did his master's thesis at the University of Minnesota on this exact topic. So this was one of his later papers that showed a post-surgical case. And I just want to show you a little bit about the case. This shows the x-rays that they had at the time. If you look at the image on the right, you'll notice in this sort of right above the orbits, which are these circles down below, this collection of flecks of calcium that it looks like symmetrically distributed and occupying, part of the brain at least that turned out to be basal ganglia. So this is one of the first images of a patient who had post-surgical hypoparathyroidism. On the left is shown a skull X-ray image that shows the same thing from the side view, but this patient apparently had what they called spontaneous parathyroid insufficiency. At that time, we didn't call this pseudo hypoparathyroidism, but back then, that's what they had. So images that show similar calcification, a little bit more on the patient on the right than the patient on the left, but this is what they had and this is what they knew. This is the patient who had the post-surgical. And so you can see the same distribution of calcium in the side view, panel A, and then looking at front to back on the right, but showing similar distribution of calcium. The previous patient, both images actually were for pseudo-hypoparathyroidism or spontaneous hypoparathyroidism. Reading through the paper, I'll tell you that they knew about the spontaneous hypoparathyroidism before they knew that it could occur in patients who had undergone parathyroidectomy. So post-surgical hypoparathyroidism was, in a sense, discovered later than the spontaneous hypoparathyroidism as noted. Now, the paper describes certain features here, and I just put this up for you to read at your leisure here. They mention the fact that they are doing research on symmetric cerebral calcifications. The previous communications were published by various authors starting in the mid-1930s, and a thesis was even done by this Dr. Eaton. Dr. Eaton was a neurologist here for many years, starting in the 30s, who became famous, more famous in some ways, for describing what's called the Lambert-Eaton syndrome. This is known today as myasthenia gravis, but this is the same Eaton who described basal ganglia calcification essentially for the first time. So they emphasized that symmetric cerebral calcification was often associated with spontaneous parathyroid insufficiency. And in their opinion, these changes in the brain resulted from this parathyroid insufficiency. This was not well established or taken at the time to be true, but their hypothesis was that this was the case. And they said this hypothesis could, of course, be somewhat strengthened by the finding of symmetrical cerebral calcification in a patient who had undergone post-operative parathyroid insufficiency, but they hadn't found a patient yet at that time to describe. So this is their first report. And they said they thought the reason they couldn't find such a patient was that earlier years, they weren't taking x-rays of the skull at the time after parathyroid surgery, at least not routinely. And in this case, this is one of the reasons why they did the study. So they found this, and they said that if patients who have postoperative parathyroid insufficiencies properly diagnosed and treated early, many patients with spontaneous parathyroid insufficiency typically remained untreated for many years because there was no parathyroid hormone at the time to treat these patients. And it wasn't even clear at that time that necessarily calcium, phosphorus, vitamin D, calcitriol, magnesium might even be considered. So it turns out they knew or recognized at that time that in most cases, spontaneous parathyroid insufficiency was severe, whereas most of the patients who acquired the deficiency after surgery had it to a less severe degree. So even though we think that's a relatively modern concept, it turns out maybe it wasn't. It was actually known in the 1930s. So they presented this case who had cerebral calcification. Now, turning more to the modern era and modern concepts, of course, we know the diagnosis of hypoparathyroidism is based usually on three key things. You have to have low calcium, increased or upper normal serum phosphorus, and of course, inappropriately low, normal, or decreased intact parathyroid hormone. This is well established in the modern era. I won't take the time to show you all the other biochemistry changes that can occur in patients with hypoparathyroidism, because for today's purpose, these are less relevant. So the risk of complications of this condition are also fairly well known. This is a paper from the Journal of Clinical Endocrinology and Metabolism a few years ago, showing mostly data from the Aarhus in Denmark, Lars Reinmark's group, and looking at the evidence of post-surgical hypoparathyroidism with risk of complications and the non-surgical or spontaneous hypoparathyroidism, if you will. And so if you look at the risk of hospitalizations for the various complications, you notice that the what's called HR hazard ratios are increased. They're above 1.0. That's how we know they're increased. And you can see what's called the confidence interval, how low and how high they were at the time, and then compare them to the patients with non-surgical hypoparathyroidism. And what you notice is the non-surgical hypoparathyroid patients have greater increased renal insufficiency, kidney stones. Not so much information was known in this study. Ischemic heart disease seems to be more common. Neuropsychiatric disease, more common in the non-surgical patients. Seizures, definitely more common, about threefold more common. Cataracts increased also about threefold. And then, of course, upper extremity fractures, it turned out, still a conundrum at this point. In post-surgical hypoparathyroid patients, there was less risk. Hazard ratio was below 1, whereas in the non-surgical patients, it was increased. It was 1.93. So generally, you get a sense of there's a difference in behavior, a difference in the expression of the syndrome, depending on whether you have post-surgical or non-surgical. And of course, nowadays, most people have post-surgical hypoparathyroidism, typically about 3/4 of the time in most of the recent series. Now, what I would draw your attention to is the last line in the table. This is intracranial calcifications, and this includes basal ganglia calcification. It could include calcification of other parts of the brain, the cerebellum, for example. But you notice that the post-surgical patients, about half of them have been reported to have this based on various series. The non-surgical patients, more of them have intracranial calcification. So the pattern holds up that's been described even since the 1930s. These show some images of various manifestations. We won't take time today to talk about enamel hypoplasia. This is a condition that leads to abnormal teeth and tooth loss and caries, cavities in the teeth. We won't talk about cataracts. That's a topic for another time. But you can see the right eye in this particular photo has a cataract in it. It looks whiter than the dark circle on the left in the normal patient. We're going to talk in more detail here about basal ganglia calcifications. So just one thing to point out is that you notice in the 3 slides on the right side, there's extensive basal ganglia calcification. The white that's in the center part of the CT scan of the head is the basal ganglia calcification with some vascular calcification thrown in too. Whereas on the left, the single panel shows tiny dots of calcium. And of course, there's something different between the two patients. Clearly, the one on the left is less severely affected. The one on the right has more basal ganglia calcification. So for our switching to the current data that I'll present to you here, show you what study we did, how we did it, and then what the results are. There's some other background information to be aware of. In general, we know that soft tissue calcification is typically associated with changes in the calcium phosphate ratio in the blood. Sometimes we talk about the calcium phosphate product, shown in the next bullet. This is associated with blood vessel and soft tissue calcification in patients receiving hemodialysis for their stage 5 chronic kidney disease, end-stage renal disease, where the kidneys don't work. They do dialysis to keep the patient alive. And of course, there's blood vessel calcification in this condition, generally correlating with calcium phosphate products, where you just multiply the blood calcium number and the blood phosphate number together, and that gives you the product. Now, there's guidelines for our kidney specialists, the nephrologists, called the KDOQI guidelines, published 2010. There was a KDIGO, a separate set of clinical practice guidelines issued in 2009. And the consensus was back in 2010 that trying to keep the calcium phosphate product less than 55 milligrams squared per deciliter squared in late stage CKD might help protect against blood vessel and other soft tissue calcification. So the question is, if that's what they do for the kidney patients who are going into end stage renal disease, how about patients with hypoparathyroidism? Do we need to have a similar or different goal for the calcium phosphate product in patients who have chronic hypoparathyroidism? And I'll give some answers to these questions as part of our study. It's still unclear why the basal ganglia, in particular in the brain, seem to have a greater likelihood of calcifying in patients with chronic hypoparathyroidism. It's not intrinsically obvious why the basal ganglia should be the ones to be calcified, whereas other parts of the brain less often so. We mentioned earlier, there are times where the brain can calcify in other parts like the cerebellum, other parts of it as well, but the basal ganglia by far and away are the most commonly calcified. There has to be a reason for that, and that's one of the things we were trying to figure out. The first X-ray description of spontaneous basal ganglia calcification was from 1939 from the Mayo Clinic here in one of the earlier papers that are still not included in PubMed, by the way, that they're referenced in the later paper. That was the 1947 paper we talked about. We know that most of these soft tissue mineral deposits are composed of calcium and phosphorus. There's interest in phosphate metabolism more than in the past because now we have a new molecule called fibroblast growth factor 23, FGF23, that seems to be a major regulator of serum phosphorus, mostly functioning to tell the kidneys to lose phosphorus in the urine when the serum phosphorus is too high. But there's also more known about parathyroid hormone. And so even with emerging information on the pathophysiology of blood vessel calcification that's come from the kidney disease patients, the causes for basal ganglia calcification are still relatively unknown. So this is the abstract from the paper. I'll just kind of walk this through you to introduce you to the paper. Guido Zavata was the fellow who was the lead author on this paper. There's other authors from our radiology department and then myself on the paper too. You can actually look this up in the Journal of Clinical Endocrinology and Metabolism if you want. So the objective was try to look at the prevalence and the factors involved in the pathophysiology of basal ganglia calcification in the brain, trying to figure out why people get this, and to evaluate some of the previously proposed pathophysiologic mechanisms. People have thought in general that probably high phosphorus is a major factor. This was what's called a case control study. We compared patients known to have the disease based on their billing code diagnosis that we can search in our very large patient database here in Mayo Clinic Rochester. We have over 13 million patients that have been seen here in the past, not as big as some insurance claims databases or others, but the advantage here is that we have full records on everybody, either through the clinical charts, paper charts prior to about 1997, and then electronic records after that. So it's very easy to search the electronic records database without actually having to go back and pull charts from the warehouse and look up the records that are still in handwritten notes that we can see. This was done at a single medical center. We went back from 2020 to 2000 itself, January 1, 2000. So we had records over 20 years. That means whatever number of patients we have, we're going to have a lot of follow-up data. And so we thought that would be important, trying to recognize various factors. We found, it turns out, 142 patients who had chronic hypoparathyroidism out of the 1,014 patients we identified. So we were looking for patients who had the diagnosis, but also had a head CT scan that were done somewhere between January 1, 2000, July 9, 2020. And then what we did is we age and sex matched the patients to control patients without hypoparathyroidism who had also had head CT scans over the same interval. So looking at a patient cohort, comparing it to a control cohort without the disease, but matching them 3-to-1, it turns out. We could match more controls to the patients we had. And so that increases the strength of our findings and make sure that our comparisons are going to be more accurate than they would be if we just had one control per patient. This was an observational study. There was no interventions done. All the interventions the patients had were done for clinical care. And we're just sort of, in a sense, looking over the shoulders of all the different clinical care providers who took care of these patients over this 20-year interval. And what we looked at was population-based information, age, height, weight, all those things. We looked at biochemistries because, of course, all these patients were seen with various biochemistries. And then we had the CT scans with actual images we could look at, and then go back and semi-quantitate the volumetric estimates of basal ganglia calcification. If you think about this, basal ganglia calcification is like kidney stones in a sense. Kidney stones are in the kidney, of course, but right now our imaging technology allows us to estimate the volume of kidney stones. And so we went to our radiologists that do this and said, can you apply the same technology to basal ganglia calcification? And they said, yeah, why not? We thought there would be more discussion, but they said, no, they can do it. And they have the technology to do it. So that's what we pursued in this paper. So the study major conclusions are that a quarter of the patients, of the 142 patients who had hypoparathyroidism and had CT scans over a median follow-up of 17 years had basal ganglia calcification. Now, the head CT scans were done clinically, not by design, but by clinical indication. So people who had headache, head trauma, car accidents, many other reasons got CT scans. And of course, some of the hypoparathyroid patients got them for the same reason. So this is the population we're comparing. This is not a sequence of everybody with hypoparathyroidism getting a head CT scan as part of a research protocol, because that would be very expensive and time consuming to do. We're just looking at what we have. So it turned out that the patients with hypoparathyroidism were developing basal ganglia calcification at a younger age than control patients without hypoparathyroidism. If you said, why would control patients get basal ganglia calcification anyway? Well, they get it because of neurologic disease, hypertension, diabetes, other conditions that lead to stroke and heart attack. And so a small percentage of the control patients also had basal ganglia, but not as big as what was found in the patients with hypoparathyroidism. It turned out that about 5-fold more patients developed basal ganglia calcification in the patients that were non-surgical compared to the post-surgical. So again, illustrating that hypoparathyroidism in non-surgical patients is more expressed, it's more severe, and even this is also affected by about 5-fold more. It turned out low serum calcium and low calcium phosphate ratio correlated with the presence of basal ganglia calcification. And unlike in other studies, we did not find a link with serum phosphorus or the calcium phosphate product. I'll show you the data in a little bit. We found that lower serum calcium was associated with a bigger volume of basal ganglia calcification, and also noted that the extent of the calcification varied widely, with generally the non-surgical patients having a greater volume and distribution of calcification, sort of like what we've mentioned. So we concluded at this point that basal ganglia calcification, it's associated with low serum calcium and a low serum calcium phosphate ratio, which may be related to severity of the disease, the etiology, or the duration of treatment. Now, this shows the beginning of the study in a sense. I'll go through these slides fairly quickly because I don't want to tie it up and leave you with confusion about these things. But just to show you what we can do here, these are patients who had billing code diagnoses of chronic hypoparathyroidism between January 1, 2000 and July 9, 2020, when the study started. These patients were all previously registered for research when they checked in for clinical purposes. So this is one reason we get away with doing this kind of research in the database here. And we found 1,014 patients that had chart review verified diagnoses to make sure the diagnosis was correct. We also found others who had been diagnosed with hypoparathyroidism, but really had hypothyroidism, had hyperparathyroidism, and other diagnoses that sound like but weren't hypoparathyroidism. So we reviewed all the charts after we got the clinic numbers from this. This was IRB approved and there was no limitations there. And then when we went through the 1,014 patients, 142 of them had CT scans that we could access. So that was the cohort that we started with. We then went back and matched by age and sex the 142 patients we had in a 1:3 ratio with subjects without hypoparathyroidism who had CT scans performed and had been seen over the same duration, January 2020 and January 2000 and July 2020. There was about 120,000 of those that we had. And then we looked at those that had serum calcium measurements within 90 days before they had CT scan to be able to say something about pathophysiology that might affect their findings. That was narrowed down to 49,000 patients. And then from there, we further winnowed them to match by age and sex at least the disease patients that we had. So that's how the study was done. This is all done electronically, by the way. And if you got the right search engine, you can do anything. So this is what's been obtained. Now, this first table summarizes the demographics or the characteristics of the study population. You'll notice that there's the 142 patients in the top under hypoparathyroid patients. Controls, there was 426. The p-value says, is there any difference between the numbers? And a p-value generally of less than 0.05 is a statistically significant value. So we're looking for changes that we can tell between the two cohorts, hypoparathyroid patients and the controls, and seeing if they're different in any respect. So you notice here that women were about 2/3 of the total, both in the cohort of hypoparathyroid patients and in the controls. If you look at other things here, you'll notice that ethnicity for Caucasians, especially white Caucasians, no difference there. The p-value is 0.418, non-significant. And then you can see the distribution of a few non-Caucasian patients that were in there. By etiology, it turned out our cohort, 80% were post-surgical, and further down under non-surgical, you'll see it was 19.7%. So this was roughly about the same as been reported from other series where it's 75-25. There's some variation in that. We had 80 and 20 roughly. Among those that were post-surgical, most of them had had thyroid cancer surgery, a smaller number thyroid surgery from benign causes, an even smaller number who had had parathyroid surgery. And we found 2 patients who had MEN1 or 2A that have hyperparathyroidism usually, and they had had surgery too. And there's a smaller number who had had other head or neck surgeries. In the non-surgical patients, you can see that we found a fair number of autoimmune patients, either because they had adult onset or autoimmune polyglandular syndrome type 1. That's a childhood diagnosis that leads to this condition. You can also see we found a fair number of genetic causes, including DiGeorge syndrome, trisomy 21, activating calcium sensing receptor mutations, or a known familial history, but the gene at the time was unknown. And then finally, a smaller number of idiopathic or unknown cause. So this is the distribution of the cohort. You can see it's pretty similar to most of the other cohorts that have been published. When we look at characteristics, you can see here some important findings. The age at diagnosis, these were people mostly in their mid-40s when they were diagnosed, but you can see that they ranged in age from almost birth to age 84, so a very broad range of diagnosis, but the mean or average was 44 years. Duration of disease at the time of the head CT scan turned out to be 11 years. So this is not 20 years, but it was a fairly long, lengthy period of time to be able to say something about what these patients had. The age at the CT scan of the head was shown to be on average age 62, but the age went from 11 to 97 years. So we had a very broad range across the spectrum. Number of CT scans per patient averaged 1. So unfortunately, we didn't have a lot of patients who had multiple CT scans in the same patient to see whether things progressed or changed or went away perhaps. But we did have one patient who had up to 22 head CT scans over the timeline that he was followed. Duration of the follow-up averaged 17 years. The post-surgical patients averaged 17 years, non-surgical patients 16.5 years. The age, the number of patients alive at follow-up was about 2/3, 66% in both the cohort and the controls. You can see that. And then the age at the end of study was again, early to mid 60s, showing there with quite an age range also. One of our patients lived to 100 with hypoparathyroidism. The controls lived to 105. You can see that. And then, of course, body mass index, looking at were these patients overweight, they were about the same. They were mildly overweight, which is pretty typical for the American population at this point. Now, other characteristics that might impact their ability to form tissue calcification, we looked at smokers, we looked at alcohol use, we looked at the percentage who had diabetes, hypertension, cholesterol problems, and then we looked further at the main reasons for getting a head CT scan just to see what the differences were. And then finally also looked at the number of patients who had basal ganglia calcification. And so what I'll emphasize here, there's a lot of information, but the patients who had basal ganglia calcification, we found 36 patients with hypoparathyroidism, 25.4% of the population that we studied, whereas in the controls, 7.3% had basal ganglia calcification. So you'll see that the controls do get it, but much less commonly than the patients. And if you look at the non-surgical versus post-surgical, of course, you notice that more non-surgical patients got this and compared to the post-surgical cohort, even with 11 years of average follow-up. This slide shows a lot of information too, and it compares statistically the group with hypoparathyroidism on the left, second and third columns, the controls in the fourth and fifth columns, and then the statistical analysis is on the right. And you can see that we compared basal ganglia without basal ganglia in the hypoparathyroid patients. We compared it in the controls, basal ganglia versus not. And then we also compared patients with hypoparathyroidism who had basal ganglia calcification to those who didn't have hypoparathyroidism, but who also had the basal ganglia calcification. And so there's more information here than we'll take time to do, but this gives more specific details. And what you'll notice is there was some of the areas that are bolded in the p-values that are on the right three columns. Those are the ones that were statistically significant. So for example, the hypoparathyroid patients comparing basal ganglia versus those who calcification versus those who didn't have it. When we looked at the non-surgical patients, of course, there was a statistically significant value difference of less than 0.001. I won't take the time to filter down through all the other reports, but you can see that, for example, age at head CT scan was statistically significant in the control group, but also comparing the basal ganglia group with hypoparathyroidism to the basal ganglia group that was in the control group, and more data to be shown there. Let's talk a little bit about biochemistries. This gives the details, obviously, of what we've done. What we did is we looked at the single calcium value nearest to the CT scan of the head to get a sample of what the patient was doing at the time versus what's called the time-weighted serum calcium. The time-weighted serum calcium takes all the calcium levels measured in the patients over the entire period of follow-up and averages them. So this, in a sense, tries to minimize the fluctuation in serum calcium over time, but it gives us a snapshot of where they were. We did the same thing for phosphorus. We did it for eGFR, estimated glomerular filtration rate, using the modification of diet and renal disease equation, one of the commonly used equations to estimate renal clearance, creatinine clearance, in a sense, using serum creatinine, age, height, and weight of the patient to get further estimates of kidney function. And then we looked at creatinine, the kidney function itself, both singly and then time-weighted. And then we looked at the calcium phosphate product as well as the time-weighted calcium phosphorus ratio. So on here, you can see that basically there's a lot of data again, not so many statistically significant values. There's only a few statistically significant values. But for example, it turned out the time-weighted calcium to phosphate ratio, the last line on the slide, turned out 0.007. That was statistically different between the patients with hypoparathyroidism who had basal ganglia calcification versus those who didn't. We did not find a statistically significant ratio or value for the calcium phosphate product, interestingly, or phosphorus. So this is one of the things that is different from other studies. We then looked at all sorts of other biochemistries that matter, calcium phosphate product above 55. We looked at magnesium. We looked at parathyroid hormone itself. We looked at 25-hydroxyvitamin D. We looked at calcitriol. We looked at urinary calcium and creatinine, trying to figure out were any of these things predictive. And if you notice the p-values in the hypoparathyroidism column, third from the right, essentially every one of those is above 0.05. So there's no statistically significant differences between any of these parameters predicting what we found. Now, this lists the medications these patients were treated with. You can see the number of patients who got various calcium supplements, calcitriol, magnesium thiazide, et cetera, in the middle column, and then on the dose that they took, the mean dose they took on the right. And these, we did this to make sure these people were treated like most patients are with hypoparathyroidism these days, with doses similar to what most people get. We then looked to see whether the patients with basal ganglia calcification, comparing those who didn't, had any difference in the doses, and the p-values on the right and the bottom third of the slide here show no difference in the p-values, which means that the patients who had basal ganglia calcification weren't taking more calcium or more vitamin D or something to explain the difference. So this doesn't help us much trying to figure out why the patients had basal ganglia calcification. Now, this table shows how big the basal ganglia calcification was in the brain. And this is semi-quantitative. It's using this kidney stone analysis applied to basal ganglia calcification. And we look at the volume, the density, and the variance in the parameters measured. You can see that the total cohort, the volume on average was 0.075 ml, not very big at all. So that's good because that means most patients shouldn't have neurologic symptoms correlating with this. The post-surgical patients, on the other hand, had a little bit lower volume, 0.02 ml, whereas the non-surgical patients, 2.15 ml. That p-value, 0.011, was statistically significant. So there's a difference in the group with surgical and non-surgical hypoparathyroidism. Individual patient data is shown on the the left side of the column here, showing the volume estimates, ranking them from lowest to highest. You can see the highest estimate was 42.93 ml, down at the bottom of that second column from the left. If you look at the follow-up head CT scans in the patients where we could do this, we actually looked to see, was there a change over time from baseline to follow-up head CT? And basically, you can see the interval between these different head scans running between, looks like the lowest was 14.3 months, the longest looks like 102.7 months. So quite a range of difference there. And yet the difference between baseline and follow-up head CT volume estimates wasn't all that great. There's slight changes, but not huge changes. And this kind of gives us a sense that the people, by the time they were first diagnosed, they had it already. It didn't change much over the next number of years as they were followed. But this is the first time anybody's been able to semi-quantitate the ganglia calcification. This image slide here shows the amount of basal ganglia calcification in the lower right half of each of the panels. So if you see here on the left upper panel, panel A, in this, there's a yellowish small few dots there. That's the lowest that we found. If you go across to panel B, there's a bigger amount of calcification in the basal ganglia. If you look at the panel C on the bottom left, even bigger yet. And then on the right side, the biggest that we had, you can see that the volume of the calcification goes quite variable between these different patients. And of course, the head CT images generally match what you see on the images of the basal ganglia calcification. Now, we then went and looked at how big the calcification was and tried to correlate it with all sorts of parameters we thought would make sense to try to see if there's any correlation. And what you'll notice is there was bolded in darker letters p-values that range from quite low, less than 0.01, for example, with a correlation between density of calcification and the Hounsfield unit value, comparing it to volume of calcification. So that was significant. There was also correlations with age of diagnosis of the hypoparathyroidism, the serum calcium level, p-value 0.025 there, serum creatinine 0.018, and that was it. When we look at the volume of calcification in the middle column, less impressive values on the right-hand side, nothing is bolded there because all the p-values are above 0.05, looking at density of the calcification in Hounsfield units. So this gives you some sense about, is there a correlation between, say, serum phosphorus? We didn't find it. Calcium phosphate product, we didn't find that, et cetera. But this is the best correlations we have looking at underlying pathophysiology as to why this might occur. Finally, we looked at the neurologic complications that were diagnosed in these patients and their controls with or without basal ganglia calcification. This is important because it's known that in the literature, at least, there is publication of various series from India and elsewhere that seizures are common. And it's oftentimes said in case reports even that I get to review every now and then that if you have this condition, there's commonly associated seizures. So we looked at all the neurologic diagnoses we could by billing codes. We looked at evidence of any neurologic diagnosis. We looked for Parkinsonism, tremor, seizures, ataxia, lack of coordination, cognitive impairment, dementia, cerebrovascular disease, even headache, memory loss, sleep disorders, and musculoskeletal symptoms. These are all separate billing codes under the neurologic rubric. And we compared everything and we found nothing. So this was a disappointment at one level because other studies have shown correlations. On the other hand, this is what we have and the data is the data. So in our series of, say, upper Midwestern patients that were being followed here for 20 years, we couldn't find neurologic diagnoses correlating with the development of basal ganglia calcification. And of course, you could think of many reasons why that might be the case, but that's the data. So coming to the end of the study, we found on some of the images here that you can look at with colorimetric changes, different densities of calcification. So green is more dense in this image than the pink. The pink around the outer rim shows Hounsfield units of a certain range, less dense than bone. The green sort of matches the density of the skull that's in the white line around the perimeter there. And so different parts of basal ganglia are differently calcified. And that's not something really obvious. You might think it would happen, especially if you're piling on calcium on the outer surface of what's already been accumulated. Maybe that would make sense, but this is the imaging that we have. So that was something that our radiologists didn't expect to find, but that's what they saw. Secondly, this just gives you a spectrum of what we saw on basal ganglia calcification. The patient on the left panel, panel A, was 53 years old, male, had familial hypoparathyroidism diagnosed at age 7 years of age, so lived most of his life with the condition, and yet he had basal ganglia calcification only in certain parts. And so maybe not as impressive as you might think for a guy who lived that long with this condition. The middle panel, 69-year-old man who had post-thyroidectomy hypoparathyroidism since age 26. So he lived for a shorter number of years with the condition, but had post-surgical, and of course he had more extensive calcium deposits. Some of the white dots in the black spaces down at the bottom of the panel there, those are actually blood vessel calcifications, not basal ganglia calcifications. So that's something else that suggests maybe this condition can cause vascular calcification as well. The third panel on the right side, panel C, is a patient who had no evidence of hypoparathyroidism, but he did have hypertension, diabetes, dyslipidemia, all of which lead to calcification of various things, blood vessels especially. And it turned out the arrow shows a little punctate calcification he had on one side. There was a matching one on the other side, but so faint you can barely see it. So it gives you a sense of what the difference is between healthy people who have basal ganglia calcification, usually due to other disorders, and what this condition seems to cause. Finally, this shows sequential images. The two top are patients that were taken with autoimmune hypoparathyroidism. And because of our Zoom control panel here, I can't see the text, but I believe this was like 11 years apart. Not showing a huge amount of difference between the two, but you could guess that the panel on the right shows a little bit more calcification than on the left. The one on the bottom shows a patient who had brain tumor requiring a lobectomy. Part of his brain was taken out, and he had 3 head CT scans performed over 13 years. You can see in the panel on the right, there was more calcification than there was in the middle panel, hardly any, if at all, on the left panel. So it gives you a sense of how fast this can progress and what you might expect to see. So this is the last slide from the research presentation. Essentially, you can see that we found about a quarter of the patients followed over 17 years had basal ganglia calcification on the head CT scans. It turned out that it developed earlier in patients with chronic hypoparathyroidism than in the controls. It was much more common, 5-fold more common in non-surgical patients than the post-surgical patients with hypoparathyroidism. There were low serum calcium and low calcium phosphate product that correlated with the presence of the basal ganglia, and that lower serum calcium associated with greater volume of basal ganglia calcification, and that non-surgical patients tended to have a greater volume of distribution and content of calcium. Now, a few last slides to kind of wrap this up and put it in perspective. There have been a number of other studies performed over the years looking at the same issues. We find slightly different data in some respects, similar data in other respects, but in general, the conclusions that I could give you is that if you have basal ganglia calcification without hypoparathyroidism, it tends to be small, faint, asymmetric, limited to the globus pallidus, and slowly progressive. If you have basal ganglia calcification due to chronic hypoparathyroidism, the calcification tends to be more dense, symmetric, bilateral, diffuse, and more rapidly progressive. The globus pallidus is the single basal ganglia nucleus that seems to be most frequently affected. And this has been reported in other studies from India as well as elsewhere too. Not clear why that's the one that takes the biggest hit from this, but that's the data. Symptoms are variable. Some series report symptoms, others don't. Ours didn't. We couldn't identify any. So, but other studies do, and it's not clear. The general sense is that there's a correlation between extensive calcification and presence of symptoms, but we had patients who had pretty extensive calcification with no symptoms. So there may be more than meets the eye at this point. It's not obvious why the basal ganglia calcification doesn't develop in more patients with chronic hypoparathyroidism. To really say that for sure, we'd have to do serial studies on patients with the disorder. And of course, clinically, that's not allowed at this point or not felt to be necessary, but perhaps someday that will be, and it will clarify this more. And then finally, the calcium phosphate product time weighted even showed a basal ganglia in the patients with basal ganglia that it was 38.1, not close to 55, and yet they still had calcification. So the implication is even with these kind of calcium phosphate products in the low to mid 30s, this may not be protective. And so that's an important clinical consideration, obviously. Now, other studies I've just shown here, some prevalence of various studies. The top bullet is general population who have punctate basal ganglia calcification. You can see there over different time frames that this identification is variable. It increases with more recent studies because the technology is better. CT scans of the head are better now than they were in the 1980s. So that makes sense. Those who have idiopathic hypoparathyroidism, a number of series have shown higher prevalences. You notice even up to 91.7% in the series by Sachs. What about patients who have chronic hypoparathyroidism of the more typical type? You can see the series here from Michelle Rubin and Deb Mitchell looking at their figures, and their figures are quite variable as well, 12% versus 53%. So not always clear why. Now, my last slide is to summarize what we know. And like most research studies, you oftentimes hear it said that you do the research to find out answers to questions you have. And what you find out is more questions that don't have answers than you found out answers to the questions. And that's what we found. So the mechanisms of causation do remain unclear. There's a correlation with low calcium in the blood. Low calcium phosphate ratio is all we found. We didn't find phosphate or calcium phosphate product issues here. The onset and the time course of development remains unclear. Most of our patients who had the diagnosis had full-blown basal ganglia calcification when the first CT scan was done. We were hoping to find patients who progressed over time to give some sense of that. Didn't find a single patient that had significant difference anyway. So these were all early on development after the diagnosis. It's uncertain why basal ganglia calcification is more common in the non-surgical patients, maybe greater duration of disease by the time they're followed or studied, could be, but it could be other things too. There's some evidence of progression in the patients on serial imaging, but not very much and not nearly as much as we thought we would find. It's still unclear from this study whether we can reverse this with treatment of chronic hypoparathyroidism. These patients, based on the time era, were mostly treated with conventional therapy. I think we had 3 patients, if I remember, that were treated with Natpara when it was on the market. Not enough follow-up to really say anything about that, but maybe we'd hope that that would reverse basal ganglia calcification, even like it, in a sense, hopefully prevents chronic kidney disease and kidney stones, all that. And then finally, from our data, it's really uncertain as to why some patients get neurologic symptoms and some don't. There has to be a correlation with severity of disease, but it's not clear what exactly that means, because we had patients with pretty severe basal ganglia calcification and yet no clinical diagnosis of a seizure disorder, Parkinsonism, or other findings. So I'll stop there. I hope I'm within a few minutes of what our stated time was, and I'd be happy to try to answer questions for you if you have any based on this information. Thank you for your attention.
Well, thank you. There's quite a few questions actually, and we'll give some time for those. And this one is from Sissy. It's kind of two parts. It says calcification in soft tissues and vascular related to hypoparathyroidism. Is it increased? And can hypoparathyroid patients have increased calcified blood clots?
Well, so the first answer I think is easier. From the information that we saw in the imaging that we have, we suspect there is a relation. That's not yet been proven, however, and that's one of our future research goals, is to look at the same population and see what about vascular calcification. And thinking of this, we're thinking about the brain, we're thinking about the heart, we're thinking about the kidney arteries, we're thinking about the leg arteries. So theoretically, yeah, any one of those could be affected, or all of them. We don't know. And because, for the studies that have been done to date, I don't think we're seeing endpoints of any of those calcifications that are known to be increased risk. But theoretically, that's awaiting further research. Now, blood clots, none of this really directly affects the risk of blood clots. And because blood clots are thought to be due to many other factors unrelated necessarily to the hypoparathyroidism, you'd say, well, if you did clot somewhere and they didn't take it out, could it calcify eventually? It's well known that inflammation in blood vessels leads to calcification in the healing process. And maybe even if there was a blood clot thrown that lodged somewhere in a blood vessel, it might calcify over time. I'm not aware that that's more frequent in this hypoparathyroidism situation than it is in other situations, but we see that in otherwise normal people without hypoparathyroidism. So that's, again, I think, an answer that would probably better wait for future research. So,
okay.
We have a question from Zara. For people on conventional therapy, does taking vitamin K2 help to prevent these calcifications?
Yeah, so short answer is we didn't measure vitamin K in our patients. That was not one of the medications we searched for either. So we weren't expecting people to be taking this, as they oftentimes do with other conditions that vitamin K is thought to be beneficial in. So the short answer is I can't really answer that question at this point. That would be an interesting thing to look at for future research.
Okay, and this one's from Nancy, and it says, I've been diagnosed with Parkinson's. Is there a test besides an MRI that would tell if it's actually Parkinson's or basal ganglia calcification?
Yeah, so that's a very good question. I mean, Parkinson's is a clinical diagnosis made based on certain features of the disorder. People tend to be relatively rigid. They move slowly. Sometimes they have what's called resting tremor, where the hands shake, but they're not doing anything with them. These are all features of the condition. And usually when they're all present together, it makes it pretty easy to make the diagnosis. Now, if a CT scan of the head or even an MRI was done at the time to make sure it wasn't other conditions, I suspect they would have seen basal ganglia calcification had it been there. But of course, lots of patients get Parkinson's without basal ganglia calcification too. And so, this correlation, part of the reason for doubt about the correlation is that we see conditions that have calcification without the tremor and without the features of Parkinsonism, others who have Parkinsonism, but no basal ganglia calcification. And so I don't think there's a one-to-one correlation. I think there's a relationship, but not true in everybody.
So they want to know, is there a reason for hypopara patients to get a baseline imaging? And then after the baseline imaging, would it be recommended to have regular maintenance imaging?
Yeah, that'd be a great research study. Problem is your insurance companies generally won't provide for that because we'd love to do it. They won't let us do it because of the cost. And the guidelines, the current hypoparathyroidism guidelines, I'm sure you've heard at this meeting that there's new guidelines coming. Even the new guidelines being published sometime after January 2022 don't include a consensus on whether everybody should get a CAT scan at baseline or any point during follow-up. Certainly they would be obtained if there were neurologic symptoms like Parkinsonism or tremor or seizure disorder, things like that. Problem is, what about all those people who don't have those symptoms? Well, we'd be spending a lot of money doing CAT scans. So the general sense is it's not there yet. Now, based on new information over time, as things come out, it may turn out this is a useful test, but I think for now it'd be premature to say that.
Okay, and then, and this is from Vicky, and it says, if I read or saw the information correctly, renal stage 2 and creatinine seem to have a correlation. Would that seem to indicate that patients having multiple episodes of overly high calcium and renal failure should have a CT to identify basal ganglia calcification?
Yeah, I mean, certainly that'd be one interpretation. On the other hand, like I said, in the current practice, in the current environment that we're in, insurance companies don't want to pay for anything they don't have to. And so to argue to get the coverage for a CAT scan just because of stage 2 chronic kidney disease or worse, even with kidney stones or kidney failure, there's not a direct connection between those things and abnormalities in the brain established yet. Hopefully future research will show that if it exists, but right now I think again it's a premature thing. And if the doctor is willing to do it because he says you've got symptoms that would fit with that, go ahead and get it. Otherwise, if you're asymptomatic, I think you're going to have a hard time trying to get it.
Okay. And then we have a couple people asking, is it better to get a CT scan or an MRI for this type of diagnosis? And if a CT scan, is it done with contrast? Yeah,
so CT scan picks up calcification more frequently than the MRIs do, but MRIs see more. And so, for example, if they think you've had a stroke or mini stroke, they'll do an MRI. They wouldn't do a CT head because the MRI is better. Depends on the symptoms that a person has as to why they do the imaging. So to some degree, it's driven by what the underlying diagnosis is or thought to be. But like I said, CT head is done for many other reasons too. And so we pick these things up usually incidentally, they just show up when you get the CT scan for other reasons. So this is why, there's not a strong correlation so far, but obviously there may be, and it's useful to know if there is. So this is, again, I think, subject for future research. So.
Okay, and this question is from Kelly, and I think it's relating to the calcium phosphorus ratio. But why would lower calcium phosphorus ratio levels be correlated with more BCG? And she's like, I would have expected the opposite, more or less.
All right. So a very good question. We were surprised as well. The problem with research is you get data that doesn't fit your hypothesis. And all of a sudden we're saying, what's different? So make a long story short, if you think about this, if calcium sort of in a sense complexes with phosphorus in the blood as well as in soft tissue, if calcium levels go low, that would allow more phosphorus perhaps to migrate from the blood vessel into the basal ganglia. And if it's the calcium phosphate product in the ganglia that would cause the complexation and then the formation of the ganglia, that could be potentially an explanation. The problem is, this is what we've got. And the ratio, also calcium phosphate ratio, if it was lower, it predicted that would mean lower calcium in the blood, higher phosphorus in the blood. That would also potentially give you another explanation. But these things are not clear. We know calcium and phosphorus cross the blood-brain barrier. Parathyroid hormone is not thought to. There's a lot of complexity in this as to why you'd form it. And then, maybe analogous to this question, why is it only in the basal ganglia? Why isn't it more commonly in the cerebral cortex or the cerebellum or these other parts of the brain that should have access to the same calcium and phosphate in the blood, at least? So this is, like I said, fruitful for future research questions, because if other studies confirm this, maybe this will give us further insight into pathophysiology that would explain this. So.
Okay. This person is asking, is there, so since there seems to be a calcium phosphorus correlation to having basal ganglia calcifications, would taking a phosphate binder help lower your risk for BGC?
Yeah, that's a very good question. I mean, that gets to therapeutics. You know, if we said, well, if people normally have upper normal or slightly increased or sometimes a lot increased serum phosphorus because of hypoparathyroidism, if the phosphorus is that high, doesn't it sort of leak into places that it might not otherwise? Certainly it could. That might be a factor for causation of this or other soft tissue calcification eventually. When we say calcification also, it's usually we're talking calcium phosphate deposition. And of course, calcium doesn't just deposit by itself. It binds to something else, phosphorus most commonly. So therapeutically, if you kept your phosphorus under what the guidelines say nowadays, 5 or 5.2, 5.3, something like that, it should theoretically at least minimize the chance you're going to get soft tissue calcification, kidney stones, many other things that we want to prevent. On the other hand, the data has not been shown to be incontrovertibly there yet. So again, I think this is, fruitful for future research questions. So.
Okay, and then one last question, and it's, can you ask Dr. Clarke? Well, I guess I'm asking you now. Are there neurologic and imaging studies looking at the cessation of pain due to hypocalcemia in hypoparathyroid patients that you know of?
Yeah, not to my knowledge, but like I said, I'm an endocrinologist. I don't interface with our neurology colleagues every day anyway, and most cases not very often. There may be studies going on that I'm not aware of, certainly, because I mean, this is of great interest, and pain is a huge thing, certainly within adult humans, and trying to control pain is a huge thing. And there's a lot of research going on. I wish I knew more to the answer to that question, because it would be directly applicable to many of my patients who have pain on top of their hypoparathyroidism. Maybe some of the research going on in Europe at the Aarhus and Denmark may show further insight on that eventually, but I'm not aware of anything else in the near term that's looking specifically at pain. So.
Awesome. Well, thank you so much, Dr. Clarke, for the time, your time this afternoon. And it was very interesting study. And I'm going to love to go through this again and dig more into it, because there's a lot there. It was really cool.
All right. Well,
Yes.
thank you very much for the opportunity. Yeah.
Thank you. We just have a couple of short announcements. Thank you again, Dr. Clarke. For patients, the questions that did not get answered today by Dr. Clarke, we will get them answered for you and be posting them. We will get the questions, the videos, and everything together, and we will send you an email in the next few days. The survey that we sent out twice today, most of you chose to answer anonymously, which makes it really hard to give out t-shirts. So because of that, we've decided, we thank you, first of all, for filling out the survey and taking the time, because many of you did. But we'll do a t-shirt giveaway, but we're going to do it a little differently. And we're going to take those of you that attended the sessions today and randomly pick 5 of you, and we'll contact you and get that information so that we can send those to you. Before you close out your event site today, any of those documents that are on the left-hand side, you can go ahead and download those or whatever for personal use. Any other documents, slideshows, videos, again, will be coming very soon, and we'll get in touch with you in the next few days.
Yep. And just so everyone's aware, when is it? Our next conference will be live. We're going to do a hybrid, is what the plan is. It's going to be in Los Angeles next year from November 4th to 11th. It's going to be in conjunction with FICA again in Los Angeles. So we're going to hopefully see you in person. If not, we'll see you through video chat. But this has been an awesome platform, and I don't think we'll ever not use it. So thank you again for everyone's patience and for everything that we've done and gone through. And thank you. I can't thank you guys enough.
That's awesome. Thank you, guys.
And the conference is November 4th through the 7th, next year. You said 11th. You said 11th.
Oh, 4th through the 7th.
It's a really long conference.
Well, maybe I was just thinking extra
Thank you,
vacation
everybody.
afterwards.
Thank you, guys. Have the good rest of your day.
Bye.
Thank you.
God, this stuff is rolling in here.